Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled Introduction to the Health Workforce Analysis Guide, Part 1, and it was presented by Gene Moore and David Armstrong on November 17, 2016. Hello, my name is David Armstrong, and I'm the Director of the Health Workforce Technical Assistance Center. And today I'm joined by Gene Moore, the Director of the New York Center for Health Workforce Studies. And today's presentation is the first in a two-part series focusing on the Health Workforce Analysis Guide that we recently published. This guide is available for download on our site at healthworkforceta.org. And for those of you who would like to view our previous webinars, they are also archived on that website. Now, after today's presentation, you may ask questions using the chat panel on the right of your screen. With that said, make sure you send your questions to all panelists so they'll have an opportunity to be asked. Also, when the event ends, you will be directed to a short evaluation survey. So please provide us with your feedback. We would greatly appreciate it. Now, with that said, I think we'll go ahead and get started. Gene?
Thank you, Dave. Good afternoon, everyone. Today, we're going to talk with you about a report recently released by the Health Workforce Technical Assistance Center, and it's called the Health Workforce Analysis Guide. This actually updates a similar guide that was funded by HRSA and developed by the Center for Health Workforce Studies back in 2000. And we were really excited about the opportunity to revisit what we had developed and think about things that we want to share with you about health workforce analysis. I think it made us realize just how much has changed in this area, both in terms of data and methods for health workforce research. We designed the guide to provide assistance to anyone interested in conducting health workforce research. And again, with a focus on things like issues associated with primary data collection, although we don't go into a great deal of depth on that, but a much stronger focus on secondary data sources that we think are really important and relevant for health workforce research. And finally, a description of basic, intermediate, and advanced methods that researchers use. And again, this guide, I think, really reflects a lot of the changes that have been going on in healthcare delivery and how that's impacting demand for health workers. So we really recognize that health workforce research questions of interest are changing. And honestly, back when that last guide was developed, you know, we used to conduct a lot of profession-specific research. How many physicians do we have? Where are they? Do we have enough? And I think the changes in healthcare delivery has really refocused health workforce research. You know, so as we move away from acute care with a much stronger emphasis on primary care and prevention, greater concern about cost, quality, and access, attention to population health. We ask different questions, broader questions, and a lot of times it starts with the question, what do patients need, and what are the best workforce strategies to deliver those needed services? So the organization of the guide, there's really three components: data sources, measures, methods, and models, and examples. And we decided that it was just too much to try to cram into one webinar. So we decided to have a two-part series to introduce the guide to interested parties. And today's webinar is going to focus on two aspects: measures, methods, and models, which Dave Armstrong is going to talk about, and then special challenges for health workforce research, which I will cover. There's a second webinar that will be held on December 7th. We will be sending out a meeting notice shortly, and that's where there's much more of a data focus. And so we will touch on issues associated with primary workforce data collection, but a much more in-depth discussion of sources of secondary data used for workforce research, strengths and weaknesses of those sources, and examples of health workforce research using those sources. So now I'm going to turn it over to Dave, who is going to talk with you about measures, methods, and models.
Thank you, Jean. The material I'm going to be discussing today is primarily drawn from Chapter 3 of the Health Workforce Analysis Guide, and Chapter 3 is aptly named Health Workforce Analysis. This chapter is divided into roughly two parts. First, we discuss basic terminology, and then later on, we focus on a conceptual framework for health workforce analysis. So to begin, I just kind of want to go over some basic terms that we hear thrown around a lot when discussing health workforce research. And mind you, some of these terms may be a bit antiquated in some respects compared to the new focuses today, but at the same time, you do need to realize and understand how they fit into the bigger picture, since they're all very much part of the discussion. One of the basic terms that you always hear discussed is supply, and this, of course, simply refers to the overall supply or number of available health professions in a certain geographic area or within a particular setting. How many are available to work? Demand, on the other hand, is really more of an economic concept, and it refers to the willingness of employers to hire health workforce professions such as nurses, physicians, etc. And then need, well, need's kind of a bit trickier because this is really a normative judgment of how many health workforce providers you need for a particular population. And so you often see discussions of supply and demand models, and the one reason why you tend to see demand discussed more so than need is because it's much more easier to measure, albeit I think there's a much greater awareness now that we really do need to be focusing more on need. Other terms that you see thrown around regularly include shortage, which refers to a situation in which there is not enough health workforce providers in a particular area, setting, region, etc. Surplus, of course, refers to a situation in when there is a surplus of health workforce providers. And maldistribution, well, this is really a key one, because when you talk in these broad terms of shortage or surplus, it tends to mask over a lot of things. Because in a lot of situations, say in a state like in New York, we have an abundance of physicians, but they really aren't distributed proportionally across the state. So overall, New York State has a large physician supply, but when you start looking at the county level, you realize some counties have less physicians than others, while some counties have a surplus of physicians. And so there's this maldistribution at the county level. Now, in this first part of the Chapter 3, we also discuss some indicators of shortage, such as direct measures such as patient wait times, or indirect measures such as turnover rates and average time before you can hire a new employee. But what I really want to discuss today is a conceptual framework for health workforce analysis. That is, when you start a project, what questions should you be asking? You know, how should you organize it? And so let's go ahead and jump into that. This is our framework for health workforce analysis that we developed. And it is really just a conceptual framework. And one of the things we thought was very important when we created this guide was to make the framework that it could be used by all levels of health workforce research, that is, by the most experienced health workforce researchers, but perhaps even more importantly, people that are new to the area, to help point them in the right direction of how to get started. And so essentially there's three major categories to this framework: study purpose, study characteristics, and study data. And next, I'm going to go ahead and discuss each of these areas in a little bit more detail. Study purpose. Understanding the study purpose, the goals of the study, is critical for having a successful project. If you aren't clear on the study's goals, you can be led astray. You can go down paths that simply aren't meaningful to the individuals who want you to conduct a study. And there's multiple parts to the study purpose. First, there's the overarching goals of the study purpose. For example, perhaps your project, the main goal is assessing the adequacy of the behavioral health workforce. But then within that, you also have more specific objectives, such as determining the number of behavioral health workers required to serve a population. And of course, it wouldn't be a health workforce study if there wasn't specific health professions involved in the project. And so another point to the study purpose is determining what health workforce professions you're focusing on. Are you just focusing on psychiatrists, or are you also focusing on psychiatric NPs, psychologists, social workers, caseworkers, and of course there's a plethora of other professions out there too that are relevant. And keeping this in mind will ultimately lead you to choosing the correct data sources for the project, and will also let you know what methods you should choose for the project. So understanding the study purpose, your overarching goals, the specific objectives, the health professions that are involved, that will ultimately keep your project on track so that it is successful. Next, we have the study characteristics. And there's three categories or three dimensions to the study characteristics. There's the theme, the sophistication, and the methods. Now, the theme essentially refers to, well, what type of study is this? Is it focusing on the supply of health workers, or perhaps the demand or need for health workers? Or are you looking at the adequacy of the supply? That is the supply sufficient to meet the demand or need within a particular geographic area or within a particular setting, such as long-term care facilities? Another way to consider the study characteristics is the level of sophistication. And the level of sophistication will become more relevant as we continue to this discussion. But first of all, we attempted to classify the level of sophistication into three categories: basic, intermediate, and advanced. And really what I'm talking about here is the types of methods you use and the types of charts and tables you present in your results. So for example, a basic study and analysis generally focuses on counts of health workers and relatively simple indicators of demand. Charts, tables, and maps tend to be based on simple counts and population ratios. Intermediate levels of studies generally include more detailed or elaborate statistics, trends over time, or more detailed breakouts of supply and demand statistics for different geographic regions and population subgroups. Tables, maps, and graphs tend to be based on multiple variables. And then, of course, there's more advanced studies. And here we're getting into some more advanced statistical techniques, multivariate analysis, which are designed to reveal underlying patterns and relationships amongst several variables. These results often include multiple dimensional indicators and supply and demand projection models. And so the level of sophistication for any particular study is not, these aren't hard and fast rules, but we set this up as more of a heuristic to help point researchers of different levels of experience into the right direction. And of course, another important aspect of the study characteristics is the methods. There's simple methods such as counts, ratios, comparisons. There's multivariate regression models, time series analysis, modeling, et cetera. There's a wide slew of methods available to help workforce researchers to consider when they begin a study. And this is how all of these characteristics are related to each other. This chart shows the interrelationship between the theme, that is it a workforce demand or need study? Is it a supply side study? Or are you looking at the adequacy between the demand and the supply? And of course, within these major categories, you see the different levels of sophistication. So for instance, a basic health workforce supply study would be, say, figuring out how many physicians in New York deliver direct patient care. What is the supply of these physicians? And that could use some simple counts and ratios to do so. But even at that level, things aren't always that simple, which we'll get to here in a bit. Next, we have the study data. Now, next, In our next webinar, we'll be discussing data and data sources in much more detail, so I'm just kind of going to go ahead and skim over this. Ultimately, there's two major types of data sources. There's primary data, which of course refers to data you collect yourself, and you may collect this data yourself via surveys, interviews, or some other mechanism. There's also secondary data sources, which are essentially existing data sets, existing things that you have access to, which someone else collected. And whether it's primary or secondary data, there's a variety of types which fall into each category. For instance, administrative records. Those could be like claims data sets. And of course, surveys, interviews, and an important facet of this is, what if two data sets imply something different? How do you reconcile the differences? All these topics are covered in this chapter, but like I said, I'm not going to really touch too much on them today. Another important aspect of the study data is the data elements. What are the supply characteristics available in a data set, or the demand characteristics? What type of information do you have on a particular physician within a data set, or RN, LPN, et cetera? Do you have their demographic information, education, et cetera? Sampling is also an aspect of study data. You have a universe of interest in any given study. Perhaps your universe of interest is all RNs working in the U.S. But the problem is, it's generally not practical to survey or interview all RNs. So generally what you do is you take a sample. And the sample may be a probability sample, or it could be a non-probability sample. A probability sample implies that each RN who is working in the U.S. has a known probability, a known chance, say 2%, of being included in the sample. A non-probability sample, on the other hand, refers to a situation where you do not know that probability. And so probability samples lend themselves to inferential statistical analysis. Non-probability samples, not so much so. They're really convenient samples, such as if you went down to the mall and started handing out surveys to people who are passerbys. With that said, there's a place for everything, of course. Another large component in health workforce studies in regards to the data is geography. And I'm going to get back to this one here in a little bit. So we'll hold off on that for now. But first, let's talk a little bit about understanding your data. And here's an example I alluded to a little bit earlier. What if you were given the task of estimating the number of physicians providing direct patient care in New York? This would be basically a basic health workforce supply study, but, you know, albeit it's basic, it doesn't mean it's not without complications. There's a lot of factors to include even in such a basic study. At first glance, it would seem you could just go to the local licensing board and ask them, well, how many licensed physicians are in the state? And as we can see in 2010, there were approximately 86,000 licensed physicians in the state. But you know what? Not all of these physicians were providing direct patient care. In fact, a decent proportion of the physicians were not even active in medicine. That is, a decent proportion of those physicians, approximately 6,000 here, were either retired or no longer practicing. So that's a factor you have to consider in estimating the number of physicians providing direct patient care. Another factor is that a number of the physicians that are licensed in the state may not actually be practicing in the state. They might actually be practicing in an adjacent state, but simply maintaining a license in your state. And so all of a sudden, we're down from 86,000 to 70,000. And what do you want to do about residents? Do you want to count them? Do you want to exclude them? Or what about the fact that some individuals work more hours a week than others? The point being, there's a lot of factors to consider even when addressing such a simple health workforce question. And at the end of the day, in 2010 at least, we decided that there was approximately 54,000 full-time equivalent patient care physicians practicing in New York State. Okay, next I'm going to go ahead and talk a little bit more about geography. Well, there's three major dimensions to geography which we're going to address. Units, that is units of analysis, address, and migration patterns. And by units of analysis, what I mean is, well, what are the boundaries you're using? Are you looking at states? Are you looking at counties, zip codes, et cetera, census tracts? The units of analysis that you choose can greatly impact your study. If you focus on a state, you may miss observing maldistributions of healthcare providers across counties. Similarly, if you focus on counties, there may be a maldistribution within sub-county levels. So you have to be aware of that when you go forward. Another thing to keep in mind with different units of geography is they're not all congruent. While census tracts add up to counties, which add up to states, zip codes, the boundaries of zip codes often cross county lines. And so you have to be aware of these distinctions when you're putting together distinct data sets. Another large problem for many health workforce studies, and some of these problems you just have to do the best you can by all means, is address, or specifically practice address. Many data sets do not even tell you what the address attached to a provider is. So, for example, that physician address, is that a practice address? Is it a mailing address? Or perhaps a billing address, which might be halfway across the street from the practice location? It's very common for certain files to just provide a mailing address. I know, like in New York, the New York licensure files, those addresses are actually just contact addresses. They may or may not be practice addresses. So you have to be careful of how you use this information. After all, if you're using mailing addresses in the place of practice addresses, it can be very misleading. A good example of that is in New York State, Westchester County is where a number of physicians live. It's a suburb of New York City, but a lot of these physicians actually practice in the Bronx, which actually has a lot of medically undisturbed areas. Another consideration is migration patterns. That is, and I'm talking about both provider and patient migration patterns. Providers move. They change practice locations, and so an address that was up to date 2 years ago may no longer be up to date. So that just introduces some more potential error into the data you're using. These are things you just have to keep in mind as you go forward. But you know, perhaps an even larger problem is patient migration. Let's say there's 150 family or primary care physicians per 100,000 population in a given county. Well, what does that mean if half of that county's population receives their care in another county? Or what if, in addition to serving all that county's population, those primary care physicians are also serving the county population of Y and C as well? So it kind of throws off the meaning of that ratio and how you can interpret it. Granted, there's not always a good way to answer those questions, but it's something to keep in mind as you go forward. Let's dive into another example, and these next couple examples very much show you how geography can come into play. Okay, here we see a slide showing the primary care health professional shortage areas, HPSAs. These are federal designations in New York, and most of you may be aware of these, and these are basically indicators of shortage. Granted, they may not be the best indicator, but it's what we have. And just for those of you who aren't familiar with upstate New York, let me tell you, we have about 4 major cities in upstate New York. Do you care to guess where they are? Here they are. This is Buffalo right here. Then you travel east a little bit, you have Rochester, Syracuse. Over here is Albany, Rensselaer's right there. This is where this live broadcast is coming from. And then, of course, you go down to New York City. The point being, there's a saying in New York, if you want to find the physicians, you can just follow the thruway which runs through all of these cities. And so as you can see, most of the primary care health professional shortage areas in New York are actually in the more rural areas of the state, not so much the suburbs surrounding the city. And so with that said, as you can see, there's a big difference between rural and urban areas, and that's another factor you always have to consider during your analysis. These are very distinct places. Okay, in the next map I have. And note that the darker areas, the purplish color, is actually the HPSAs, is a map of New York City. And, you know, this is somewhat counterintuitive. As most of you are aware, there's a number of providers in New York City. So, well, how do we have these HPSAs there? Well, it's very simple. These are not geographic HPSAs, so that is, they aren't targeting the entire population of a given area. Instead, these are special population HPSAs in New York City. These are for the Medicaid-eligible population. The point being, we have tons of physicians in New York City, but you know what? That does not mean that everyone living in the city has access to them. There's different barriers. There's a lot of insurance status, et cetera. So it's another thing to keep in mind when you're doing your studies. Just because you have a sufficient supply of providers, it does not mean that individuals have sufficient access to them. Okay, that really concludes my overview of Chapter 3. With that said, one of the things we really wanted to do when we created this guide was to, help new researchers, provide them with examples, activities they could do that are relatively simple. And so we included a chapter devoted to, examples of good, well-done health workforce research from around the country. And we organized the chapter using this typology, and then you probably recognize this a little bit from earlier. On the top, we have the levels of sophistication, and then they're broken down by the theme, like supply, demand, need, or adequacy. And so it basically creates this 3-by-3 table. Now, ultimately, we decided that there are no basic adequacy studies. But nonetheless, this is how we decided to organize our chapter on health workforce examples. And so I'm just going to kind of run through a few of them real quick for you. The first few slides are from South Carolina, and I'd like to thank Linda, Nicole, and our colleagues down there for sharing these with us. This is from a data book that many of you are probably aware of. And this particular map shows you the supply of RNs in South Carolina by primary practice location. And what you see here is each dot represents an RN down to the zip code level, and so you see this cluster of where the different RNs are located in the states. It's one way of looking at this data. And so you can really see where they're at. It's kind of appealing in some senses. But of course, it doesn't take into account all the factors. Here's another map using the same data, but looking at the information in a bit different way. Here, we're looking at the concentration of RNs per 10,000, as we're looking at some rates. How many RNs are there per 10,000 population for a given county? And if you go back and forth between the two maps, you can see that there's a large correspondence to a lot of the areas, but there are also some differences. So it's an example of using different data, using the same data and looking at it in different ways to get as much information and understanding out of it as possible. And here's a third slide from that data guide. And while there's just a wealth of information on this one, this is for Charleston. And you can see up top here, there's the name of the county, but also some information on once more HPSA designations. Apparently in Charleston, part of Charleston's a primary care HPSA, part of it's a mental health, and part of it's a dental care HPSA. Then underneath this, you have a lot of supply information on providers. That is, you have physicians broken down by specialty type. You have a few rates here. You have nurses, you have dentists, and some other health professions. So there's really a treasure trove of information here. What really gives you perspective on this slide is the other information, the demographics. After all, what if this was a particularly older population? Well, then you'd probably need more healthcare providers to serve that population. Or how about the vital statistics and health status indicators? Socioeconomic data, facility data. What if this was also an especially poor population? Well, that would also imply something different for the amount of healthcare providers you need. Next is a poster that was done by some colleagues in California Janet and company, thank you for sharing this. Now, that said, this is actually a nationally focused study, and what it looks at is trends in LPN workforce from 2008 to 2013. And essentially, it just looks at ACS data, and it compares LPN information from 2 time points, from 2008 for the ACS, the American Community Survey, to 2013. And what you see is an interesting trend starting. You see that LPNs are increasingly working in long-term care settings while they are decreasingly working in hospitals. In fact, there's also some projections out there that suggest this trend will continue. So really, a relatively simple study, just taking 2 time points and comparing the data, can provide you with some very interesting results. And the final example I went ahead and threw in is actually from New York. It's from the New York Center for Health Workforce Studies. And we've been collecting data on residents since 1998. That is, we have an ongoing New York resident exit survey. And one of the really neat things about having an ongoing study is that you can track trends over time. Now, this particular slide is just a snapshot from 2015. And it shows our relative demand indicator by specialty. That is, what's the relative demand of one specialty compared to another. And this demand indicator is actually kind of a composite measure. That is, it's made up of several different variables. For example, just to throw out some of the variables we use, percent difficulty finding a job, percent having to change plans. Also, there is a case where trends in income, is income going up or down for a specialty? Perception of the regional job market, perception of the national job market. All of these indicators we combine into a composite measure. And we actually use 4 years for a particular for a particular time point as well, weighing the more recent year more heavily. Anyway, the point being, what we have observed over time is some dramatic changes in the landscape. And as you can see up top, family medicine is ranked #1. I will tell you, this is the first time they have ever been ranked #1 since we've been tracking this data, which goes back to 1998. In fact, if you go back to the early 2000s, well, they weren't ranked #1, let's just put it that way. In fact, what we've observed over time is that there's been a dramatic shift in the demand for primary care in general compared to specialty care. As you can see, general internal medicine is also up there. And this started happening around 2008. We started really seeing demand for primary care surpass specialty care. But anyhow, this is just one more example of a type of health workforce analysis you can do. And this one here was mainly intended to show you the power of data over time. With that said, I'm now going to go ahead and turn the presentation back over to Jean. She's going to discuss some special challenges for health workforce analysis.
Thanks, Dave. So these are the topics that were actually listed in the guide we developed. And honestly, I think at times the sands shift so much that while these, I think, are certainly representative of the kind of issues that researchers need to think about, they too are subject to change. So let me start by talking about the first one, new professions and occupations. So there's a lot of different reasons why these things happen. Sometimes it's in response to unmet need for health services. A key example right now relates to dental therapists, advanced practice dental hygienists, in an effort to try to create better access to restorative oral health services. Another is, the evolution of more effective diagnostic and treatment protocols. And, we've certainly seen that in the use of stents for placing cardiothoracic surgery and growth in demand for interventional radiology. Another interesting one is the need for more cost-effective workforce strategies to increase access to services. And we are seeing a lot of interest and development of unlicensed workers like care coordinators, patient navigators, case managers, care managers, and hybrids where a medical assistant might be trained to provide health coaching or motivational interviewing. So there's a lot going on, and honestly, with the lack of standardization in titles, qualifications, educational requirements, it's really tough to understand their impacts on patient outcomes. And I think there's kind of a double whammy because we're moving to more team-based models of care. These are important members of the team, so as you're trying to kind of further understand impacts on patients, again, it's tough to understand their contribution when there's so little standardization related to that. Another important issue is scope of practice variation. So we know that states are primarily responsible for regulating health professions. And legal scope of practice is what a health professional is allowed to do and not do in a given state. And oftentimes what we find is mismatches between professional competence, and that is what a health professional is trained and competent to do, compared to legal scope of practice. And as a result, there tends to be a lack of uniformity in scopes of practice across states, particularly for some professions. Probably the best examples are nurse practitioners, dental hygienists. And again, this variation complicates efforts to assess productivity, to evaluate professional impact on patient outcomes. I think that the silver lining in that cloud is that this variation actually can support research that allows a systematic study of the impacts of broader scopes of practice on outcomes. Now, I threw this in at the last minute just as an illustration of scope of practice variation and kind of the drama associated with it. So this was prepared, actually put together by a group, Barton Associates, who hires locum tenens providers. And one of the things they realized is, given the variability in scope of practice for NPs, that they really needed to provide NPs information about what they could and couldn't do in the state that they were going to practice in. I really think it's a fabulous way to help policymakers and planners understand how variable things are. And again, that coupled with studies that show impacts of scope of practice restrictions on patient outcomes, really can drive home some important messages. So, I think we all know that the education and training of health professionals is a really important policy lever. And, sometimes as we are challenged with shortages, we think about, well, we've got to produce more, but sometimes it can take so long to produce more graduates that, it may not be sort of timely for providers who are struggling with, how do I get the job done today? I also think it's difficult to turn the spigot off. So what happens when you've ramped up, increased production, and now you might be heading toward a surplus? So again, I think that it's really important to kind of track that information and recognize that the education sector really needs to be involved. Another interesting issue relates to collaborations between educators and providers. I think there's growing recognition that we are needing workers with different sets of skills, with workers who are prepared to work in team-based models of care. And it's just not clear if the education sector fully understands what that means. So again, I think the need to create more collaborations between educators and providers is really important. New technologies. Again, this is an example of the revolution in technology is pretty incredible. So things like better diagnostic capabilities, new treatments for diseases, reducing treatment costs by finding better, safer ways, and telehealth. So I will tell you that in New York there is a daily bulletin that comes out called Crane's Health Pulse. And I've started tracking all of the reports of kind of interesting new uses of technology in care delivery. One is a group developed an auto-refractor device for on-demand eye exams. A hospital developed a mobile stroke unit that connects the ambulance with the hospital. It comes with a CT scanner, and it comes with 2 specially trained EMTs. A digital ER, where people who show up and don't have really serious problems, and again, it may be those folks who are looking for care that probably could have been delivered, you know, in a primary care setting, are diverted to a telemedicine option where these people with less severe problems are seen via a telehealth connection, and it actually reduces wait times. Again, I think that it's hard to fully understand the impact of technological innovation on worker supply and demand. Sometimes we may need fewer of some and more of others. Sometimes we're looking at new roles for existing workers. So I think that there's a lot going on in that area, and it's very, very challenging to manage. I also think there are issues particularly associated with telehealth around reimbursement, around regulations, and honestly, payer skepticism about the value of it. And so I think that we certainly need to think about opportunities for research in that area. Data limitations. You know, as David mentioned, and we all agree, relevant data are essential for the kind of work we do. And it's really important to understand the limitations. So one of the things that I will tell you, and I can give a great example of, so inconsistent variable definitions. So in New York, everybody is dying to know how many physician practices are there, and that's one of those deceptively easy questions that's impossible to answer. So we actually purchased a data set, and we said, okay, we want all physicians in private practice. And so we got the data, and they said, yep, that's it. And as we looked at the data, and actually it was looking at addresses, and we're like, oh my God, that's an FQHC. That's a hospital clinic. And we realized we didn't get private practices. We got any physician in an ambulatory setting. And so inconsistent variable definitions, even when you think you're getting what you're supposed to be getting, can really be problematic. You know, issues around small sample size. What is the N? Is it sufficient? Is it sufficient for generalizability? Dealing with missing responses. I think that, you know, one of the strategies that we've used, if we've got a 75 response rate to a survey, is that we make an adjustment so that we can look at the whole. You know, sometimes there are some less positive ways to deal with missing responses, so it's important to understand that. And then inaccuracies on the receiving end in terms of inaccuracies in data entry, data cleaning, you know, what you do with it once you get it. And let me just say that these limitations don't always preclude using these data, but you got to know what you have, and you got to make sure to acknowledge those limitations in any work that you produce using it. And finally, looking beyond data, and this is an attempt to remind us of all the contextual issues that we need to be paying attention to. So, you know, one example that may return is the impact of access to health insurance on demand for and utilization of health services. So, you know, we know things that people who are insured are more likely to have a medical home, regular primary care provider. People without insurance are less likely to do that and are more likely to seek care sort of in a crisis mode in a hospital ED. Another area that I think I can't emphasize enough is the issue of cultural competence. Cultural competence can be a real critical barrier to providing effective care. It's very, very challenging to measure. But I also would say that I think that health workforce diversity is an incredibly important strategy that can promote cultural competence. So again, I will say from the first blush, this is not comprehensive, but these are the kind of issues that we think researchers need to bear in mind as they go forward conducting their research. So that's it for us, and now we're open to questions.
All right, thank you, Jean. And just a reminder to those of you in the audience, if you have a question, please send it to all panelists so that it has a good opportunity to be answered. With that said, I already have one question that we've received, and I believe, Jean, this one's for you.
Okay.
Can you give us an example of a research study that assessed impacts of broader scope of practice for health professions on patient outcomes?
So actually, there have been a number of studies in this area, and with a particular focus on nurse practitioners. And I will tell you that the studies are fairly consistent in terms of findings that states with less restrictive scopes of practice for NPs saw the NP capacity to treat patients increased over time. So, and another study found the frequency of routine checkups increased, quality of health care improved in states that allowed NPs to practice more autonomously. A study we did recently looked at dental hygiene scope of practice. So, a number of years ago, we developed a professional practice index for dental hygienists, and we actually ranked dental hygiene scope of practice across all states so that we could understand where practice was broader and where it was more restrictive. And then we looked at oral health outcomes and controlled for a lot of the usual suspects related to access to oral health services. And what we found was that oral health outcomes were better in states where dental hygienists had broader scopes of practice. I will tell you that that research, which was supported by HRSA, we're anticipating that it will be published in Health Affairs next month. They are producing an oral health themed journal in December, and that was one of the manuscripts that was included for publication in that. The other thing the Technical Assistance Center actually has a scope of practice webpage so that some of the work that I've mentioned here is actually, it can actually be found on the website. So I encourage you, if you're interested in learning more about understanding scope of practice for health professionals on outcomes, that you will probably find some pretty good recent information about that.
Jean, I believe we have a follow-up question. Are there any advantages to state-based health professions regulation?
You know, that's a very interesting question. So I think for a long time I really struggled with that, saying, oh my God, you know, state by state, it's so challenging, et cetera. And then I started thinking about, man, what's the alternative? Turn it over to Congress? You know, that could make it never happen. So, you know, I started thinking about it, and I guess the thing that I can say is that state-based health professions regulation really allows states to be incubators for change. An important advantage of this is a state's ability to develop local solutions to access problems and to design strategies that address local needs and considers factors unique to that state. And so, you know, I guess the negative is that it continues to contribute to state variation in scope of practice, training, qualifications, et cetera. But, you know, again, over time, one would think that, you know, we will see more convergence as states have the potential to learn from each other. And I think that's the important part is how do we create opportunities for states to understand what's going on in other states and perhaps consider those opportunities for themselves.
Okay, Jean, we have another question for you. Will the guide have any updates or standards for health professions minimum data sets? So one of the things that we decided to do in this guide was to focus more on secondary data sources. And I will tell you, it was an update of a guide that was written
a while ago where there wasn't a whole lot of primary data collection going on. And so, to be honest, it's something that I think we want to consider, or perhaps make an addendum to it. And one of the things I will suggest for those of you who are looking at the guide, we'd love to hear from you about what you think is missing. I think that there are opportunities for us to revise this and make it more meaningful to what's happening today. And again, dealing with MDS, et cetera, could be pretty relevant right now.
Okay, and I think we have time for one more question. I'll go ahead and fill this one. And it involves the physician supply study from earlier. How did you obtain data for the New York physician supply study? So one moment, I'm going to find that slide. And so this also gives me an opportunity to talk a little bit more about this in a sense. We actually have a New York re-registration survey for physicians and a number of other professions. And so it used to be the case when the state education department, where all the licensure boards are located, or most of them anyway, would send out their notices for renewal. They would also include in that snail mail envelope a copy of our survey. And so when this was the case, we actually had a very high response rate. In fact, the response rate, I'd say around 2010 was around 75% or thereabouts. But unfortunately, since we've gone to electronic system, it's really fallen off the cliff. But that's how we obtained the data. But this also gives me another opportunity to point something else out, that despite this being a basic supply study, there was even more complexity here too than I alluded to, because we only had a 75% response rate. So how do you deal with that? Well, in this case, we decided to weigh up to the whole population level. So there's actually a weight involved. After all, if we did not consider that this was an incomplete sample, we would be severely undercounting the physicians in New York providing direct patient care. So that's just another something to consider. After all, it's very odd that you have the sample that includes everyone in the universe of your interest. So you often have to weigh the data as well.
Dave, can I say something? So one of the things that's happened in New York that's been pretty interesting is that there was a change in the law for NP scope of practice, and when they made that adjustment, they mandated reporting at re-registration for NPs. And so we have one mandatory survey, the rest are all voluntary. The response to the mandatory survey has been incredible. So we have a 100% response rate, no waiting needed. So, and honestly, stakeholders in New York are thinking about ways in which we could expand data collection for all health professions using that model. So, you know, again, I just want to say that, you know, sometimes you can do something that's pretty effective for a while, but when it stops working, I guess necessity is the mother of invention.
Okay, thank you, Jean. And at this point in time, I think we'll wrap things up. Just a reminder, we are recording this webinar, and so it will be archived on our website at healthworkforceta.org. So, and also our next webinar, the second of this two-part series, will be on December 7th, and it will focus on data, strengths and weaknesses of common data sets used by health workforce researchers. And so with that said, I will thank you for attending our event, and I hope to see you again in the future. Have a good afternoon. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.